So I will try to be short and give you some context about mental health care reform and the role of evidence-based mental health care development in our country. So far, the mental health care system which we have in our country has been subject to a lot of criticism because of many things. We haven't deinstitutionalized our mental health care systems yet, as other countries in Europe, in Western Europe, and in America, Australia, New Zealand, and other countries already did. The system is underfinanced, and it's about 4% of healthcare budgets that goes to mental health. And it's financed based on tradition, not based on evidence. So we pay for the services which we paid for last year, the year before, and 2 years ago. And this directs the decisions how the money are being allocated to. There's also a huge stigma towards mental illness, which again has to do with some factors related to our past history in the second half of the 20th century, when we had communism in here. People with mental illnesses were often put to these large institutions just to be hidden from public eye, because the official ideology was that there are no social problems in communist society, and if there are, there are residues of capitalism, which led to many implications, one of them being trying to hide all the social problems somewhere. Actually, the people who were hospitalized in mental hospitals were the only subgroup of population which was allowed not to vote, because it didn't sound very good for the Communist Party that many people vote for the Communist Party. Otherwise, all the other subgroups of population were forced to vote for the Communist Party. After the revolution in 1989, there were lots of efforts to reform the mental health care. And the issues that were to be solved was deinstitutionalization, decreasing stigma, service user participation, better response to human rights, etc. But these have been always efforts of some enthusiastic professions, not a governmental policy. Until 2013, when the Ministry of Health published a strategy for mental health care reform in this country. And one of the reasons why they did it was that we were somehow able to allocate European funding for mental health care reform. And when there was a funding, politicians were much more willing to embrace the whole kind of idea of mental health care reform. So we published a strategy of mental health care reform, and the first phase supported by the European structural and investment funds. And the global aim is to increase quality of life of people with mental health problems. There are so far 10 implementations projects within the reform, which started in 2017. And these projects are led by 3 institutions: Ministry of Health, which leads 3 projects focusing on community mental health centers. That means that we are establishing new facilities called community mental health centers, which combine social care and health care together, which is pretty much a new thing. In our country, traditionally there has been this division between health care and social care. And health care was inpatient facilities and outpatient psychiatrists, and social care was community mental health teams and other social services. And usually they didn't collaborate very much together. And this community mental health center is first facility which basically combines health and social care together, which was a huge effort because there were issues such as not just financing of those, that goes from 2 budgets, but also, for example, sharing information. As a healthcare facility, you are not allowed to share information about the patient with social care facility. So all these kind of issues had to be solved. Currently, we have about 16 community mental health centers, and others are being established right now. We aim to have 30 by 2020. Then the second project focused on deinstitutionalization. That's basically a transformation of psychiatric hospitals, deinstitutionalization of patients who have been hospitalized for long term. And it's also a project which which provides an umbrella for the organization of mental health care reform. So the Reform Executive Committee works under this project. Multidisciplinary, that basically a project which focuses on strengthening collaboration between social care and healthcare services. Because of this division that I already mentioned, they were not even able to speak together. They didn't have the same language, they didn't understand to each other. This is to make them collaborate. Fourth, the other project led by Ministry of Health is New Services. This is a response to the development of the mental health care reform, which at the beginning focused very much on people with severe mental illnesses, non-affective psychosis mainly. And then, of course, we were aware that there are other groups that need new services and that need development as well. So within this project, services for forensic patients, for patients in old age psychiatry, for child and adolescent mental health services, and for people with dual diagnosis, so those in comorbidities with substance abuse as well, are being tested. Then our institute, National Institute of Mental Health, which is a research organization that belongs to the Ministry of Health officially. Otherwise, we are kind of independent research institute, providing teaching to third medical faculty students as well, and having some small inpatient department of about 50 beds. But mainly we are a research institution. And we lead a project focused on destigmatization, focused on early detection and early intervention services for people with psychosis, and this MERRPS project, which is focused on strengthening the evidence-based mental health care development in our country. And Institute of Health Information and Statistics is leading the project on analytic support for mental health care reform. These two projects, strengthening evidence-based mental health care development, MERRPS, and analytic support for mental health care reform, are projects that work together. They are complementary to each other, and the main aim is basically to change the situation that I already mentioned, this decision making based on tradition and other factors, to change it more to be evidence-based. I'm not going to speak about all these projects in detail because that would take too much time, but I'm going to speak about the MERRPS project. So we kind of like divided mental health care system as such into three levels. Macro level that deals with the system as such, meso level which deals with the individual services or individual psychiatric hospitals or individual community teams, and micro level. And all these should provide evidence to support a system for evidence-based mental health care development to fulfill some civilization value that we embrace in our culture. In this project, we focused mainly on macro level and micro level. On a macro level, we developed a system of 39 indicators, which are divided into 3 chapters, which is mental health care development, structure of mental health care system, and education and destigmatization. Each of these indicators has a proper definition, what it is not, justification or rationale, why it's considered as a key indicator, and specified data source, and the way how we calculate that indicator. So it's transparent, so we can repeat it every now and then, so we can monitor the development of mental health care system as such. These 39 indicators are, I will just briefly mention them, focused on legislation, another one on stakeholder involvement in policy making and legislation making. Third, focused on users and families involved in decision making. Fourth, regular service among users, focused on how they are satisfied with care, what are their needs, etc. Fifth, whether we have mental health plan and whether it's in line with WHO and EU policy and on national documents that we ratified in our country. Suicide prevention plan, mental care expenditures from healthcare budget, how much from healthcare goes to the mental health, and the same for social care. This is because of this division between health and social. Then expenditures that go to psychiatric hospitals from the mental health care. This is to monitor the deinstitutionalization process and whether the resources are being reallocated from psychiatric hospitals, which currently consume about 65% of the whole budget to community services. Health insurance for mental health care, information system on mental health care provision, prevalence and incidence of mental disorders, prevalence of suicide attempts, hospitalization of people with mental illnesses, numbers, length of the hospitalization, etc. The rehospitalization of people with mental illnesses as well, the rates of rehospitalization within a week and within a month after being discharged from psychiatric hospital. Mortality of people with mental illnesses, suicides among people with mental illnesses as well. And then 4 indicators focused on coverage, with outpatient psychiatrists, coverage with psychopharmaceuticals, with consecutive care, mainly whether people who are discharged from psychiatric hospitals have continuity in care in the community, and effective care. And then in the structure of mental health care systems, we focus on personnel, psychiatrists, nurses, social workers, psychologists, how many they are, where they work, what they are doing, and qualification standards for each of the profession. And then the structure of services, structure of inpatient care, outpatient, psychiatrists, community mental health centers, community mental health teams, community outreach teams, crisis services, day centers, detention care, supportive housing, mental health care for minorities, mainly Roma minority, and adherence to human rights. And then in education with destigmatization, it's destigmatization activities in our country, and education in primary health care. So these are 39 crucial indicators that we established a methodology for. Institute of Health Information and Statistics is calculating most of those indicators that are based on the regular collected data. We have the databases which are very much similar to the databases that they have in the Nordic countries. So most of these indicators it's able to calculate them from the existing data sources. Last year there was or was it 2 years ago, was the amendment of law which made it obligatory for insurance companies to share all the data they have with Institute of Health Information and Statistics, which gives you individual level data on consumption of care, being it outpatient or inpatient. So those indicators that are relevant for this are calculated from these data. So that was the macro level. This is not why we are here today, or maybe slightly. We are here mostly for the focus on the micro level, which is related to outcome scales and outcome measurements that are used for individual people who consume mental health services. So we worked in basically 3 levels. We had a research team in the National Institute of Mental Health. So those are the people in here. Then we had an international expert platform. Dan was part of the platform as well. And we had a national stakeholder platform, where there were people representing the inpatient care providers, community teams, Ministry of Health, Ministry of Labor and Social Affairs, Ministry of Finance, Center for Mental Health Care Development, Third Faculty of Medicine of the Charles University, Department of Social Work of the Charles University, insurance companies, service users, and families. So we had such a platform where we tried to achieve some consensus on these. And we had working meetings about once a month. And we focused on choosing the domains that are relevant and most relevant for outcome measurements in psychiatry. Because you can pick anything from self-stigmatization to satisfaction with services to quality of life. And we tried to come up with a set of instruments in domains that are perceived as most relevant which will be used for measuring individual outcomes in mental health services. So first we choose the domains which were relevant. Everyone was agreeing that recovery is the most important one. So recovery was one of those. Psychopathology, mostly promoted by psychiatrists. Global and social functioning, mostly promoted by community mental health teams. Health-related quality of life, mostly promoted by our teams and health economists in our team. And receipt of services to kind of monitor the cost side of the story. Well, then we went to from domains to individual outcome measures. We did, for each of these domains, we did quite a thorough review of what kind of outcome measures are used within psychiatry for measuring these domains. So we did this in recovery. We were focusing on instruments that are not too long, that are available for free, that have a good structure and kind of represent what people think this instrument should really represent, and several other criteria. So when we went to the outcome scales that are used in the domain of recovery, and as I said, there was a strong consensus on measuring recovery. So then we went to individual instruments, we presented to the platform of stakeholders, and they were saying, well, but this is not what we are trying to see in recovery. It's basically measuring optimism of people with mental health problems. And they said, we don't want any of them to be used. So after this strong consensus in this domain, we actually excluded it because no viable instrument that would be sensitive to change, etc., was found. But we had a full solution for that, which will come up later. We looked into other domains as well, and we did some, again, preliminary reviews for each of the domain, and then we discussed all these instruments that are in here, and we finally chose in the global and social functioning, we chose the HONOS. Reason for that was, and I was more arguing for HUDAS, for example, but what people said is HUDAS doesn't cover the aggressive behavior of people. And if we are to deinstitutionalize services in here, we might expect some violent behavior and some problems in media, etc. And we want to be sure that we are looking into aggressive behavior as well. And HONOS does an item which covers this, so that was the main argument for choosing. And then we chose global assessment of functioning because it's very short and it covers both psychopathology and global and social functioning. And then in terms of health-related quality of life, people were not satisfied with 5D because they said, well, it's basically not good for people with mental health problems. Only a few items which are relevant, so why would we use it? And then when we are looking at other instruments, people said, well, this assessment of quality of life, it covers what we think as recovery much more than the instruments that are used for measuring recovery. So there was a consensus on choosing this instrument to measure quality of life. So this gives you quality adjusted like here, but it also gives you some information on recovery. So we chose that one. And then when we used those selected instruments, we tried them. We, for example, assessed all long-term patients that are currently being hospitalized in psychiatric hospitals with all of these instruments. Also, people who are treated in these newly established community mental health centers were all assessed with all of these instruments. So we, for example, looked on what is the overlap between those two groups. What is the overlap between people who are hospitalized in psychiatric hospitals with those who are in community mental health centers? And we found out that about a quarter of those who are hospitalized long-term in psychiatric hospitals for severe mental illnesses have almost the same functioning and same outcomes on these three, on HONOS and GAP, as people in community mental health services. And but they don't have where to go, they don't have sufficient income, etc. We did some cost-effectiveness studies on research group assertive community treatment, which is basically assertive community treatment enriched for more intensive work with feminist users. And we tried cost effectiveness of MERRPS, which is system based on smartphones, which should predict relapse as well. So that's just some experiences that we have with this instrument so far. And then sustainability of this, there is a agreement of stakeholders that these instruments will be used to measure outcomes in psychiatry. This is not to say that everyone is satisfied with those. Many people would see better to use nothing and see it as bureaucracy and stuff, but the final consensus is in there. It's obligatory for community mental health centers, which are financed from these 3 projects led by Ministry of Health, to use these outcome measures and assess patients every 6 months with those, at least in the first period of their functioning. There is a directive which says those who could be clients of these community mental health centers have to be scored on global assessment of functioning a maximum of 70 points, not more. That's kind of who can become the client of the services. So if people are functioning enough, they are not allowed to be clients of these community mental health centers. There's a demand from psychiatric hospitals as well to have this kind of like cut-off scores, so they would have something to refer to when they are discharging patients. But so far, it's mostly based on clinicians' opinion and on clinicians' impression. And then when something bad happens in the community, there's a kind of like huge pressure on psychiatric hospitals saying, well, you shouldn't discharge the patient, you should know that he or she will do something, etc. So they're asking for these cut-off scores, there is some kind of guidance you should refer. Then there is an agreement with insurance companies, which allowed to pay for the assessment of patients with these instruments. So they pay about 1 hour of time of community mental services and other providers for assessing patients with these instruments. And if you take a look at them, it's just 3 instruments, one is self-reported, it takes about 20 minutes to get them done. And then there is 40 minutes, which allows to reflect on those scores with the patient and to inform the individual planning with the individual patients as well. And we have the collaboration with Institute of Health Information and Statistics, and all the data for these instruments are electronically transferred to the Institute of Health Information and Statistics. So they're already available within the registers and within the databases, so you can use them and calculate the outcomes. And now we are here to discuss how to organize these decision-making processes based on the data that we already have and will get from the system, and how to establish this collaboration of people to make it sure that these data are used for informed decision-making. And we are very much keen to hear from other countries how we are doing. So that was briefly from me, just to give you a bit of context. If you have any questions, I can probably answer them now before handing over to Dan, who will give us a little bit of information. Yes.
Question. That was really interesting to hear how your project's been developing. It sounds fantastic. You've achieved a lot. I have a quick question about the quality of life measure that you chose. Have you come across an instrument called REQOL, Recovering Quality of Life? The reason I ask is because of exactly the point you raised about the fact that most people don't like using EQ5D for mental health. It doesn't really meet the needs. So the University of Sheffield has developed a utility instrument. So it's a quality of life index, but you can derive qualities from it.
Yeah.
And it's called REQOL.
I heard about that project in Sheffield. It's quite recent.
It's quite recent. I think it has been translated into a number of other languages already. It's used disabilities as well. And it's quite widely started to be used now in the UK.
Are there population norms for that?
Yes.
Yes. I think that you may be referring to a different project, though, because I think that University of Sheffield is leading the development of a new, wider measure.
Yes,
measure.
Yes, that Sheffield was leading the development of this recall.
The new measure is not ready yet because they are still developing the questionnaire.
No.
I know because I'm a member of the advisory. Yeah, so that's what I'm saying, that probably you are referring to a different project because we are talking about the recent development, and I know that there is a recent development.
Well, it's reasonably recent, but it is in use. It's definitely in use. It's developed and it's in use.
Yeah. No, the one I'm talking about, they are still choosing items for the new measure. Yeah, I know that I did it 2 days ago, so I know that it's
I think
more.
we came across the goal, and I think that we didn't find sufficient number of studies that would show that it's scientific to change, that it's kind of well accepted, that it's kind of being used. Is that possible? Or has there been lots of publications on it?
It's been very much developed in collaboration with service users. It's well liked. We can talk about it more later. No, it's something to think about.
Yes, you might want to consider that.
So I think my question would be, I mean, you've, achieved a lot, and you've described, what did you set out to achieve? Because sometimes the project doesn't do what it says it's going to do, or it takes on a kind of life of its own, or whatever. You go down where there is some opportunities. So what were you hoping to get out of MERRPS when you wrote the proposal? And did it include, for example, anything about what we're talking about at this meeting, which was around, how to institutionalize it or to build capacity among, for example, policy and decision makers?
No, and it didn't include that. We hoped to achieve nationwide consensus on the outcome measures that will be used. That was the achievement that we wanted to have. But we were quite quicker than we expected, and stakeholders were very much motivated to come to that consensus because of other development in mental health care reform. Because they were like, oh, we need to evaluate these commitment centers to be able to justify their sustainability, etc., etc. So there was an external pressure to make stakeholders to come to a consensus. And second, we aimed to build capacities within our research team to be able to actually use this data and produce the sound enough. So that was only 2 projects, and then based on your advice and Wolfgang's advice, we focused also on macro level. And because we were quite faster than we expected, it allowed us to focus on the macro level as well.
Maybe it might be good to add to Petr's answer. It seems now that the insurance companies are interested in cost effectiveness analysis and based decision making more on that. So we gladly can agree to pilot this and go one step forward.
Yeah, that's a good point. I mean, what I said about decision making in mental health care is basically valid for healthcare as such. And insurance companies are main payers for the healthcare in this country. They are looking abroad. How do they do it outside? How do they incorporate evidence into decision making, etc. So we kind of like welcome this in psychiatry, so they could kind of observe it as a trial for implementing more evidence-based decision making into
Yes, I was amazed by it. Thank you very much for your presentation. But globally, you're looking at the mental health problems globally. Did you find an interest to separate some of them, like depression and anxiety problem, because it's so different from one to another?
It's a very good point. Again, it was one of the criteria for selecting these instruments as well. So, for example, Honors has an alternative for audition for psychiatry as well. So some of these instruments can be used for child and adolescent as well. and for the psychiatry as well, but not that much for common mental disorders. And common mental disorders in this country are usually treated by outpatient psychiatrists and private psychiatrists, and reimbursed by insurance companies and by general practitioners as well.
Maybe one point to check health insurance company, because you mentioned that they are aware of cost effectiveness analysis. I would like to point that there are several divisions, because we as a consultancy company, we are submitting the cost effectiveness analysis to HTA agency, State Institute for Health Insurance Companies, but then we have to administer, let's say, confidential discount, budget capping, etc. at health insurance companies. And we go there once a week, once or 2 weeks with different drugs, and they know cost effectiveness analysis very well.
Yeah.
Because they know cost per quality and so on, because you need to give appropriate discount to reach the willingness to pay threshold. Yeah. But this is a division of pharmaceuticals, but not a division of other care.
Yeah.
So within the pharmaceuticals, the system is very transparent. They know it very well. We also run some workshops for them. So they may be, if these two, let's say, divisions collaborate, there may be some fruitful results.
Very good point. Thank you for that. Perfectly right. When it comes to pharmacotherapy, then the system is much more developed when it comes to complex interventions.
So I was going to make another point about your notion about wanting to set cut-offs for HONOS and clinicians wanting that. I would resist that if you could, because you might find situations where, because a component of HONOS is also based on historical factors, and some of those, for example, with forensic patients, historical risk factors won't change. You might have patients with very low HONOS scores, but actually that could be quite risky, or they really, those thresholds aren't always what they need to be. And just one other thing to bear in mind is we did a study. We collect HONOS routinely in England, so we looked at all patients with HONOS information across England, and we categorised them into clinically reliable, significant change, and those who were stable, and those who deteriorate, and those who improve over time. For those who have 2 HONOS repeat scores. And we found, and this is not an unusual picture, you can see this in Italian data as well, that 90% of patients remain stable. So if you compare that to other kinds of outcome measures in physical health, you might not see that same picture, you would see more improvement. And we kind of question, well, what are mental health services doing? But actually, if you think about it, it makes perfect sense. Many of these conditions are episodic in nature, and actually keeping patients stable is a really good outcome. And I think that's something which, that sort of message needs to get out more. So just in terms of thinking about how you might use that repeat information that you're collecting, actually keeping patients stable is a good outcome.
Thank you for this point. You are aware of this? And the cut-off scores, it's not kind of strict rule. There needs to be guidance about it, especially for people with personality disorders. It's not actually wise to use cut-off scores like this, but they ask at least some guidance on how to use it. Because I don't know how it works in other countries. If what is the discharge from psychiatric hospital or from inpatient care baseline? Is it the impression of medical doctor, or is it just having a shift in the hospital? And so I guess in here. So we don't think this is the best alternative. Good. So over to you, John.